Thank you very much, and thank you also for the invitation to be here, and thank you for being here. 5 o'clock on a Friday afternoon, that's pretty dedicated, and I also recognize I'm between you and alcohol, so I'll be as brief as I can and hopefully interesting. If you've followed the track of the major themes in today's discussions, you probably came away with a sense of an industry in turmoil, to say the least. The forces that are acting on healthcare today are probably never more difficult, never more challenging to navigate, and certainly never stronger than they are today. And what we're seeing are all of the forces that create a sort of perfect storm. And out of this perfect storm, out of this crisis, we think there's enormous hope and enormous opportunity. And since really we're talking here to healthcare business professionals, I want to focus today a bit on that opportunity, how we turn this very challenging time, and although there's a great deal of the reform aspects, as you saw next door, that we aren't certain about at all, there's quite a bit we are certain about. And I think we have an opportunity as an industry, as a private sector, and as professionals to realize that solutions are at hand and that work can be done to make significant improvements on quality, on access, and on cost in healthcare. So if we review just a little bit, no, I didn't want that there. If we review just a little bit, you saw today an economic crisis in healthcare. Over the last year, we've seen an economic downturn that this country hasn't seen in 60 years. And in that period, 9 out of every 10 hospitals have slashed expenses. 50% of hospitals are looking at cutting staff, not just administrative or internal expenses, but actually care provider staff. 8 out of every 10 hospitals has seen an uptick in physicians that are seeking their direct financial assistance in order to keep their practices afloat. And at the same time, the ranks of the uninsured have swelled as layoffs have increased to record levels. The number of people who can carry insurance or are willing to pay for COBRA extensions simply places an additional burden on the healthcare system that it wasn't experiencing already in terms of the ability of people entering the healthcare system to provide reimbursement for the services they seek. So how'd you like to be in that business? At the same time, this reform is a very uncertain measure, and while the intent is certainly admirable, the intent to provide insurance for some 40 million or so that don't have it, the intent to be able to make the healthcare system more affordable, the intent to make the healthcare system of better or at least more transparent quality, those intentions are all good, but the questions are profound. Who will pay for that? Will there be a public option? What is the effect of that truly, the implications of that truly on our healthcare system? What does it mean for taxpayers, for companies, for individuals, for payers, and for the entire industry? This has become emotional. It's become a debate that's being challenged on moral terms rather than on economic and healthcare terms. And frankly, the outcomes are far from clear. We do see, though, and George mentioned this in his talk at noon, an increasing interest on the behalf of consumers in taking the same role in their healthcare that they have taken in virtually every other aspect of their consumption. You have no problem determining the relative quality levels of a car that you would buy, a television you're considering, even a restaurant that you would go spend $50 at this evening. and yet it's almost impossible to determine the true difference in performance of individual hospitals or of physicians for many of the most critical purchases you will ever make. It's clear that market forces, or at least open market forces, free market forces, are not at work in healthcare. And because they're not at work in healthcare, they're incapable of driving the same kind of transparency into quality and the same kind of continuous, relentless improvements in cost that every other consumer industry has seen. If today a hospital managed to do the one thing that drives down healthcare costs the most, which is to keep you healthy, to keep you compliant with your regimen if you're in a chronic disease condition, or keep you healthy if you are healthy, that hospital will actually suffer. They will receive no reimbursement for that. Their physicians have one less patient to treat. And from an economic standpoint, they see no incentive to do so whatsoever. We're also in an industry that does not value, or at least economically value, expertise. My son is in the room here today. He is a fourth-year med student at Vanderbilt. He's about to enter this perfect storm. And whenever he bills, and I hope he does bill his first procedure, he will be reimbursed exactly the same amount as a physician in the same field that's been doing that for 20 years and has done thousands of those procedures and has developed a level of expertise and quality that's second to none. And yet the reimbursement models are the same. So our view here is that while reform is certainly necessary, it will not happen and will not be effective until consumers begin to vote with their wallet and their feet. Consumer-directed health plans are a beginning. This last year, twice as many companies took on consumer-directed healthcare plans where consumers are given a wallet of money to spend on healthcare, and if they don't spend it, they carry over to the next year and the next year and the next year, in effect, building up a consumer savings plan in the event of a significant medical expense. Twice as many companies have adopted that this last year than the year before. And companies who have it well distributed through their organization experience 50% lower costs as a company to provide that same level of health care. So I think you can see that the opportunities are real. If we take a look at the part that everyone mentioned today but didn't talk about today, technology. That's really where I want to spend the bulk of my time. If you look at, and we will in a moment, where the funds that have already been provided out of the stimulus bill will be directed in health care, you'll see that the vast majority of funds are going to provide such things as insurance and better access or better coverage. A relatively small amount is going into activities that will actually affect the cost of delivery of health care. And yet, this bill, the stimulus bill, is designed to put America back on firm economic footing. When 17% of your gross domestic product is going into health care, and it's on a trajectory to go to 20% of your gross domestic product in the next 3 years, you will not achieve economic recovery. You can't keep draining the wallets of individuals and the wallets of companies and expect us to return to firm economic footings where we are spending more and more of our money on the goods and services that really drive economic growth. So it's critical to the administration and critical to us as a private sector that we get at that core problem, that we get at the problem of not only improving access, not only improving coverage, but improving fundamentally the access, the quality, and the cost of health care. Now, what does this mean? In a world where you can go on opentable.com and schedule your restaurant tonight, where you can go on Orbitz and schedule a flight tomorrow, where you can go online and schedule or pay or buy virtually anything, and converse with knowledgeable people in each of those information-based industries. I would challenge you about how many of your healthcare providers you can schedule your appointment with online. How many of your healthcare providers can you exchange an email with to find out whether you should even show up for an office visit? How many of you can conduct an electronic office visit with a physician through the same kinds of tools that you can use to get support for your printer or PC at home? In terms of quality, a large part of the quality of healthcare is based on the amount of information that a physician has when he or she meets you at the point of treatment. The ability for that physician to understand the medications that you're on, your prior conditions, prior treatments. And yet, when you enter the healthcare system, when you go see a new provider for the first time, what do? You fill out an intake form for the 37th time. All of the other intake forms you've ever filled out, all of the physician records that you've ever participated in, all of the drugs you've purchased, all of the prescriptions you're on, are unknown to that new provider. And your medical record really is you. It's what you're willing to put on that intake form. And in terms of cost, suffice it to say that any healthcare provider who relies on more than 50% of their reimbursement from the government is on very, very shaky footing and very likely to be unable to operate financially. The private payers are carrying the public payers, and yet the very people who provide the services have virtually no say in what their services cost. Now, it turns out that in every one of these areas, solutions are here. In every one of these areas, answers are here. Here in town, Vanderbilt Medical Center has one of the most advanced electronic medical records in the country. And yet, their interconnection with other healthcare systems electronically is virtually zero. It's as though you went to the bank and that bank was the only place that your financial records existed, and they couldn't possibly communicate with any other bank or credit card agency about your financial history. So, in the best of intentions, the administration has implemented the American Recovery Act. This is a phenomenal piece of legislation that took 23 days to pass. 28 days after Obama's inauguration, what was House Resolution 1 became law. Now, the complexity of this and the implications of this on a large number of industries are huge. I'm going to focus in on some of the implications and opportunities in healthcare. Overall, there's about $790 billion net impact on the federal deficit. 212 of that is impact from loss of federal revenues through tax cuts. 575 of that is direct spending that the government will undertake to try to stimulate the economy. Of that 575, about 157 billion will go to health care programs. That represents 27% of the total spend part of the bill for an economic sector that is 17% of our gross domestic product. So by a significant margin, the administration is over-investing in stimulus in health care. Where will that go? $90 billion goes to Medicaid, additional programs for state funding, largely to offset what would have been reductions in Medicaid by states who are in turn financially strapped. As the state governments begin to have serious budgetary challenges, they were signaling that they were beginning to cut back on Medicaid programs, so the federal government injected $90 billion to bail out state Medicaid. Another $25 billion went to extensions of COBRA for those near retirement, 55 to 65-year-old people who were most affected by loss of jobs. These are people who are beginning to experience significant health care costs, finding themselves out of a job, finding themselves unable to pay for health care, and so the federal government provided partial or subsidized COBRA to help them cover or bridge that period of time until they qualified for Medicare. Excitingly, $10 billion went to NIH. Now, $1.5 billion of that was for NIH to refurbish itself, build new buildings, invest in new computers and instrumentation and the like. But $8.5 billion of it went to compliance programs and other NIH programs. But this is exciting because that $8.5 billion is really designed to go to research toward best practices. How do we drive the highest quality medicine, the highest quality care at the lowest cost and achieve a higher level of compliance for that? Bill Stead today, who you heard speak, recently landed $6 million of that for a very successful program here at Vanderbilt that's had extraordinary outcomes in showing that systematized care can drive a dramatically lower cost and higher outcome in specific settings. Some other areas, but the place I want to focus in on then is this chunk of funding called high tech. It's about $23 billion. $2 billion of that is going to the Office of the National Coordinator for Healthcare Information Technology to set up standards that will now allow us to exchange healthcare information more easily and more readily than ever before, in fact, require it, to set up standards to certify that healthcare technologies meet minimum standards for providing adequate levels of functionality and that they're clinically accurate. Establishing a role for the National Institute of Standards in ascertaining and testing the accuracy and quality of healthcare technology products, and most notably, and of major impact to every vendor in this space, the provision also calls for some significantly increased standards around privacy and security, anticipating that more and more and more of our healthcare records are going online and will be exchanged electronically. The government's also seeking to protect that information, and in doing so have placed mandatory financial penalties in the event of breach of that information, $125,000 per incident, moved the adjudication of that to the state level, so the state attorney general now is responsible for the privacy and security of the healthcare records of their state and is the prosecuting arm for those organizations that breach. Mandatory disclosures to the media and to the affected populations in the event of a loss of protected health information. These are the same kinds of regulations, but in some cases more deeply enforced, that cover credit card information in the financial industry. For the first time, this set of laws with teeth now covers healthcare. The remainder of that funding, some $20 billion or so, is earmarked to go directly to providers, to physicians and to hospitals who demonstrate meaningful use, meaning, although the definition hasn't been completely determined yet, it will be determined by December, but essentially meaning that the system is in meaningful use in the physician's office or in the hospital, providing benefit, and is a system that is certified by this ONCHIT office as a system that provides the needed functionality that the administration believes will lower cost and improve quality. This includes such things as computerized physician order entry. Vanderbilt, again, a leader in developing guidelines-based physician tools that will help a physician, guide a physician, and put guardrails around the orders and medications that a physician can prescribe to make sure that they meet the standards of the organization as well as conform with research best practices, or at least offer strong advice in the event the physician chooses another pathway. Also included in this are electronic medical records that demonstrate interoperability, that demonstrate the ability to electronically transfer records from one hospital to another, from one physician office to another, and the like. So how that bill rolls out is it's kind of interesting. It's a carrot and a stick for this $19 or $20 billion. Hospitals, and it'll depend somewhat on their size, but they can partake in about roughly $2 to $8 million per hospital once they've demonstrated meaningful use. Now, the key here is the hospital has to invest up front. They have to buy the applications, install the applications, bring them house-wide, achieve meaningful use, and once they've done that, then they can receive funding to offset the investment they've made. Similarly, physicians can receive up to $64,000 per physician for installing electronic medical records in their office. Now, they have a fixed period of time to do that. To receive full payback and full funding, those systems need to be in place and in use by roughly 2013. And the carrot part of this winds down at the end of 2015. And then the stick takes over. And at that point, any provider or any physician that does not use these types of solutions will have a reduced reimbursement rate from federally provided reimbursement for health care, such as Medicare. Do you see an opportunity? There's a $20 billion opportunity out there that right now has really three conditions. It has to be the right product, it has to be installed quickly, or we're going to miss the window, and we have to believe that the federal government is going to have enough money to actually pay for this once we're done. So if you believe those three things, then you, like McKesson, sees an opportunity. So let me tell you a little bit about McKesson, not from the standpoint of a company commercial. I think we already had that. We certainly are interested in recruiting good business minds with a deep background in healthcare. But instead, to talk about where McKesson is positioned in this opportunity and why we think that it's such an important and impressive time in healthcare today, and there's such an opportunity to really affect the kind of drivers and the kinds of issues that you've heard all throughout today. First of all, we're big. We've been around longer than any pure healthcare company in the world, 176 years. We were founded the same year Chicago was founded, and we were also founded the same year that the first commercially available telegraph went up for sale. So we were there to see the start of the telecom industry, I suppose. This makes us the world's largest drug dealer, and it also makes us the company that frankly has the deepest and broadest footprint of all of the different stakeholders and all of the different constituents in healthcare. I'll go into that a little more in a moment. But it's this clinical background, our incredible investment in technology, not only for our own internal benefit, but for the benefit of our customers, and our focus on process improvement. We have some 200 Six Sigma black belts in the company who do nothing but relentless quality improvement to drive defects out of the supply chain and drive improvements in the cost of delivery of pharmaceuticals and supplies and technology to our customers. Now, the result of their work has been pretty impressive. I'll show that to you in a minute since you're business folks, but from a footprint standpoint, you can think of us as really two companies. We have a distribution side, which is very much like George's company, Cardinal. We are the largest distributor of pharmaceuticals. About a third of the pharmaceuticals that go out every day in Canada, US, and Mexico come from us. 99.9% overnight fill rates, allowing retail pharmacies to not even have to worry about inventories. We've taken that problem away from them. Largest distributor of generics, we're number 2 in the oncology market, and we just became the largest retail chain with our Health Mart franchise. We don't actually own the Health Mart drugstores, but we sell the franchise and provide all of the technology and the supplies to a chain that's now 2,000 stores called Health Mart. On the technology side, this is where the opportunity to change healthcare really lives. Distribution is a cost, and while we can make it the highest quality distribution and the lowest cost distribution in the world, it still isn't really doing anything to change how healthcare operates. The technology side is an entirely different story, and we have a footprint in some half of the hospitals in America and many examples to show of how we can actually accomplish that. Leveraging all of this together, we've had a pretty impressive string of growth. I included 4 years here, but this picture is the same going back 10, 11, 12, 13, 14 years. We continue to grow at high single digits on the top side, and we continue to leverage that through our relentless quality improvement and our productivity through technology on the bottom end to more than double that leverage on our net profits. We're a bit like the elephant to the 7 blind men. McKesson is to you as you experience McKesson. To some we're a trunk, to some a tail, to some a wall, and to some a tree. But in fact, we cover every stakeholder in healthcare, from the manufacturers of pharmaceuticals and supplies to the retail pharmacies, to you, the consumers, the payers, the health plans, the physicians, the pharmacists. We have solutions for all of these, and we touch the majority of them in the United States. For example, when you walk into a retail pharmacy and fill a prescription, and they come back and say, you've got a $5 copay, and we'd like you to consider the generic. What happened is they pinged your insurer to ask them whether that prescription was covered and what the copay was. The insurer responded back, and then once the prescription's filled, they issue a claim to the insurer. Those transactions go through McKesson. When you call 1-800-ASK-A-NURSE, chances are 1 in 3 you're actually talking to a McKesson nurse. And the list goes on. What we've realized in the last 5 years is that all of these relationships where we have strong presence and strong solutions, all of them have started to talk to us about how they connect with each other. How the retail pharmacist can connect faster with the physician to check whether or not the scrawl was correct. Or even better, how the pharmacy can connect electronically with the physician's office or the hospital to take all the ambiguity out of the script, to make it an electronic transaction instead of a paper transaction. How the physicians and the pharmacists can reach the consumers through email or structured secure messaging to deliver to them laboratory results, allergy information, their children's immunizations. all forms of electronic information from scheduling to payments. How do those stakeholders reach out to consumers? How do we take that little Vytorin card that you find in your Sunday paper that gives you a discount from the manufacturer and turn it into an electronic discount so that the pharmacist can tell you when you go fill your script, by the way, did you know that the manufacturer has a discount for you? You qualify. Would you like it? Everywhere we go, these stakeholders want to communicate with each other and can't. We've begun to fill that role, and this, more than anything else, is what excites me about the change in healthcare. I'm going to give you just 3 examples of what we've done, 3 examples of hundreds, and 3 real-life examples to show you that these solutions are here today. It's more a matter of adoption and a matter of the hospitals and physicians being able to get their minds wrapped around the business change, the process change, and the workflow change needed to drive these solutions than it is anything else. We're excited about the stimulus funding because we think in many cases these will break down the economic barriers of an industry that's severely capitally challenged and running on very thin margins to provide financial incentives to move these solutions in. So example 1, Atlantic Health. They installed an application that electronically connects physicians and patients and hospitals. So now their catchment area of some 600 physicians all share common electronic medical records of the patients that visit either those physicians or Atlantic Health Hospital. There's 16,000 patients that have access to their lab results, to their schedules, to their bills, to physician advice, to even electronic online physician office visits. And we've worked with the payers so that the physicians are reimbursed for that. And now in 15 or 20 seconds, a physician can make $25 for an electronic office visit, saving the insurance company money because the patient didn't make a full office visit for $120, saving the patient time and money because they can do that electronic visit on their own time, on their own schedule, and making the physicians more profitable because they are seeing more patients a day at a higher density than they ever were before, and saving their time for the people that truly need interventional care. It's a great story, and a story that's been repeated many times across the country. Out in my neck of the woods near San Francisco, John Muir Medical Center went after a patient safety initiative. They installed a series of applications, some of them from other vendors, many of them from McKesson. But the point is they put together the process flow, the electronic chain of custody to take medical errors out of their system. You heard today the usual statistics, 97,000 people a year die from medical errors. 747 a week is the equivalent. John Muir, in a space of a year, reduced their mortality rate by 30%. 1/3 fewer people died than they did the year before. And they reduced the number of adverse drug events that are in the harm category, those drug events that could have actually caused harm or potentially death to a patient, by 40%. 2/5 of those errors were removed from their systems. And in fact, the systems that we have out in the United States healthcare system today catch 500,000 errors a week simply by electronically checking the dose, the medication, the time, and the patient, and making sure they all match. So these are not pie in the sky. These are not futuristic. These are not impossible things to attain. They can be attained through us and through others with simply demonstrating the same kind of relentless quality improvement that every other industry that faces open competition has had to do years ago. And lastly, in the area of cost, not too far from here in Spartanburg, South Carolina, they underwent a program to essentially clean up their administrative costs, the cost to actually bill for and receive payment for the work that they provide. Went after such things as electronic authorizations and pre-authorizations, went after more efficient coding, went after better collections, made sure that people were aware of the insurance options that they had and the payment options that they had, gave them online tools to figure that out, and in doing so, took not only their accounts receivable down $25 million, but reduced their administrative costs and increased their cash flow, their free cash flow, by $3 million a month. A phenomenal attainment for a hospital that was running on less than 1% margin prior to this. So these are just some examples, and they're all over. Other healthcare IT vendors can tell you similar stories. But the important thing is that the opportunity is here. The crisis that will generate change is here. And with that opportunity in front of us, it's on us. There's nothing that has been discussed today, from breakfast to now, that is in the future so far that we can't do it, except possibly meaningful reform. The government has already demonstrated their will to tackle this. They've already shown that they believe it is important to the American people and important to the American economy, and such a priority that they're willing to spend an incredible amount of political capital to attempt to drive this change. We in the private sector need to do the same. We need to be at the table. We need to open up channels of communication among those stakeholders, people who see each other as natural enemies, like providers and payers, need to start having the dialogue about how they make this world work faster. How do I simply exchange claims and payments electronically without the 40% overhead in both the payer and provider organizations to try to do battle over how much or whether you get paid. Every other information-based industry in the world has already done this. The banking industry, the travel industry, it doesn't matter where you go. Information flows flawlessly and it flows seamlessly, and the paper's gone. Writing a check today is a fairly unusual event. 20 years ago, it was the way you paid for everything except in cash. Many of you probably remember the days when credit card swipes were on a piece of paper, and you got one copy and the retailer got one copy, and one copy went to the bank, and that one copy that went to the bank went in front of some keyboard entry person that typed it into a system, and that became the transaction. All of that paper's gone. The industry's electronic, and it's enabled an incredible commerce that we couldn't even conceive of 40 years ago. Everything from ATM machines to online banking to online auctions to online reverse auctions to online taxes. All of it virtually 100% accurate, and all of it at lower cost by hundreds of billions of dollars than the system was experiencing before this. Healthcare can do the same. The standards that are coming out of ARRA are critical to accomplishing this. The interoperability and the cooperation of the industry to do that are critical to achieving that outcome. And more than anything else, the kinds of networking and the kinds of educational opportunities that come from conferences like this that begin to open the dialogue, begin to open the doors to discussion, and begin to introduce the what can we do questions as opposed to that will never work. So I want to thank you for your time, especially at this late hour. I think, have a few more minutes for questions if you have any. By the way, I classify questions as great, good, or interesting. The interesting ones I'll get back to you on. So, any questions from anywhere? Well, that's a great question. I think you would be surprised at how many hospitals have actually invested already in healthcare information technologies. The real question is, will the systems that are going in meet the new standards that the federal government is establishing for interoperability and for feature function? Most of the major vendors, all of whom will go unnamed except McKesson, are willing to promise contractually that they will have such a capability in the reasonable future, most of them centering around mid to late of next year, which is in plenty of time to capture the stimulus bill. So we're not particularly worried, and I think most of our colleagues in the industry are not particularly worried about having effective solutions out there. We're more worried about being able to service the level of volume that we think will be created in demand for these solutions. And there's another factor at play. This carrot and stick probably is most critical to physicians, less so than to hospitals. If a physician's revenue starts dropping off 5 to 10% a year when that stick hits in, it's the difference between keeping your doors open and closed. But at the same time, many physicians' offices are not equipped to take on the technology challenges of systems like this, so they're becoming increasingly interested in remote-hosted or internet-based solutions. But all that said, the government may be overestimating the willingness of physicians to adopt. It's a pretty big hill to climb to imagine that every physician in the United States, or even the vast majority of physicians in the United States, are going to install and use and put into productive use an electronic medical record in 3 years. So.
Can you talk about the pros and cons of perhaps a patient-directed or consumer-directed health record? Thinking of a web-based record that we would participate in maintenance and update of as patients, rather than being only entered into by physicians and others.
Yeah. The terminology here bandied around, if you can take the alphabet soup, there's electronic medical record, or EMR, there's electronic health record, or EHR, and there's personal health record, or PHR. And these are somewhat overlapping, obviously, because they contain similar information, but distinctive in their purpose. There are PHRs today. We provide one, but notably, frankly, we don't think we're going to win or really have a rightful place for personal health records. More likely, that market will go to companies like Microsoft or Google, who already have those solutions out, Google Health, Microsoft's Health Trust. And they are very much like Microsoft Money, where your version of your financial records, or in this case health records, are made available to you from the systems of record, in the financial case, banking systems, and in the healthcare case, the same kinds of systems that comprise the electronic medical record or electronic health record. You can then augment that with your own information. But obviously they're going to be most effective when most of the information in there is coming from the laboratories, coming from the pharmacies, coming from the physicians' offices, and populating the record for you. And that clearly is coming. As a matter of fact, I would encourage you to go take a look at Google Health. They've already got connections to dozens of providers, many large-scale laboratories, and it's free to sign up. Give you a good sense of what you can do. Other questions?
You mentioned in your speech and the people have today as well, the fact that there's really no glory or money in preventative care. However, our country is being plagued by obesity, heart disease, diabetes, and obesity. So how can this dichotomy really fix? Because it seems like it's going to have to be.
Mm-hmm. And I want to be clear that the incentive around wellness or preventative care is certainly not in every plan, but nevertheless it's wide enough and dominant enough that it's a major concern. If you look at integrated delivery models like Kaiser, there's a strong incentive and a strong investment in wellness programs because they know it drives down their inherent cost. If you look at other essentially insurance programs that really do understand that their costs will drop if they engage in those, like state-funded Medicaids, for example, they invest heavily in wellness programs. The effectiveness of them is a little debatable, but in the main, they show a benefit. So, in my mind, this is really going to come out of two things. Number one, it's going to come out of you becoming the person who decides how you're going to spend your health care money. Right now, if you're an American in a traditional insurance program, whether you're healthy or sick, you're going to pay about the same. You might have a difference in copay, or you might trigger some, significant amount of expense depending on whether you're in-network or out-network or whatever. But in the main, you're going to pay exactly the same. So there's no economic incentive for you at all to alter anything that's healthcare related in your lifestyle other than the fact that you like to be healthy and like to look good. So when those things start hitting your wallet and you start weighing off the cheeseburger versus the Plavix, and both of those are expenses you're going to incur, then you're more likely to engage the economic debate. Secondly, it's well demonstrated in many studies that there's a huge variation, and I don't mean like double, I mean like in cases of 8-fold or 10-fold, huge variation in the effectiveness and cost of treatment from one provider to another. And the highest quality and lowest cost almost always go together. The problem is you don't know who those people are. When you do, you will shift your health care to the highest quality, lowest cost providers because you're the one that's paying for it. And as you make that shift, the high cost, low quality providers will have an economic consequence, which is called GOB, going out of business. That in turn creates free market forces which encourage entries into the market that continue to adopt these low-cost approaches. Now, interestingly, many of these highest quality providers have the most follow-up, the most aftercare contact, and the most upfront discussion, none of which insurance pays for, about options for treatment and options for better lifestyle in the event of a selected treatment. So, there's many examples out there, but in the end, I really believe that it's going to come down to consumers voting with knowledge and with their wallet. Okay. I think we got time for one more short one. A yes or no, maybe. All right. Thank you very much. I appreciate your time.